mainly on communication practice based on the latest format. So I'm sure that most of you that join tonight, some of you are going for exam in December. I wish you all the best. And those that joining here to learn about the new format or to learn something from everyone, please don't feel shy to ask any question. So we will start with just a briefing. So basically, the new format, the com skill will start first for station 1 and 4, then basically followed by short case examination. For station 1, it will be RESPI, and for station 4, it will be abdo. Okay, so usually the format is like this. As you can see, the marking scheme, I always want to stress on this table because you can see that actually com skill still is the one that will determine whether you will pass or fail by component in terms of the marking. You can see that if you do the both com skill well, and even if you, for example, screw up one of the consultation station, you will still have chance. But let's say if you screw up both or even one of the this com skill station, then it will be quite risky. Okay, for both communication as well as concern component, you can see that the marking passing mark can be quite low, as in the threshold is quite high for you to pass. Okay, so meanwhile, let's go to the candidate for today. We'll start off with Karen. Karen, are you there? Can you unmute yourself?
Yeah, hi, can you hear me?
Yeah, yeah, can hear you loud and clear. Okay,
Okay.
so I will give you 4 minutes to prepare. Is it okay?
Okay, sure.
Yeah, I know in exam is going to be 5 minutes. Sorry, yeah, it's a full 5 minutes. But I think in the setting virtually, perhaps 4 minutes should be enough. Okay, so if you are ready, I will start. Okay, 4 minutes up. Restart.
Okay. Hi, I'm Dr. Karen. I'm doctor in the clinic, acute stroke unit today. May I know, are you Madam N? Madam
Yeah,
Elaine?
Madam Elaine. Yeah, I'm Elaine.
Okay. Are you the next of kin of Madam Susan?
Yes, Susan is my mom.
Okay. All right. So, first of all, I'm actually here to explain about your mother condition. But can you just let me know first, how much do you know about your mother current condition now?
Yeah, doctor. My mother was admitted to this stroke unit because I was told that she have a major stroke. And then when she come to the this stroke unit, she was well and she's still opening eye and responding to us. However, today your nurses actually called me urgently saying that my mother condition is not doing well. So I'm not sure what happened, doctor.
All right. Madam Susan, I can see you are very worried about your mother condition. So, do you know what's the diagnosis when your mother first came to, what's the cause of your mother symptoms when she was first admitted to our hospital?
You mean her symptom? Yeah, I mean she have a left-sided body weakness suddenly, and then subsequently she have difficulty to speak. That's why we are worried. We brought her into the hospital.
Okay, all right. Madam Elaine, so your mother actually admitted is because of she has a big stroke, which is confirmed by the CT scan. Are you aware of this?
Yeah, I know about that already.
Okay, all right. And you are very right that now your mother condition, I'm so sorry to tell you that your mother condition actually getting worse in the ward because she is less responsive now. And we
Oh,
have actually
why,
repeated.
doctor? Why she became less responsive?
Okay. All right. So we actually had, because she has reduced in her consciousness level, we had immediately repeated another CT scan, and actually we can see there's actually a bleeding inside the stroke area in his brain.
Oh no, you mean bleeding inside the stroke? There's already the reason there's already stroke out. How can this happen, doctor? I was told that she was given aspirin after the CT scan was done in emergency. Can this be cause of the aspirin that you all been giving that causes the bleeding?
Okay, Madam, and then just give me a few minutes to explain this. So
Okay.
let me just explain a bit about the stroke. Actually, your mother unfortunately, your mother has a big stroke area in his brain. And when there's a stroke area, actually the blood channels in that area become more fragile and it will easily bleed. So of course, I will admit that aspirin could be one of the uh, contributing factor, but we couldn't be sure that which actually caused this bleeding in her brain right now. Can you follow me so far?
Yeah, doctor. But is it correct management to give aspirin for the stroke that my mother having?
Okay, Madam Susan, thank you for sharing with me your concern. Your concern is very valid. So actually, the stroke is happened because there is a blood clot in the blood channels in the brain. So aspirin actually serve as a blood thinner. Then when we identify there's a big stroke in the brain, we actually immediately reserve the aspirin is actually to prevent from further clot for being expanding in the blood channels and it might cause even more serious stroke. So aspirin was actually given in your mother's best interest when she was confirmed to have a stroke in her brain.
Yeah, doctor. I'm also concerned because she have a major bleeding from her bowels 4 years ago, in which the doctor also given aspirin. So I'm really worried. Like, are you sure that this is not due to aspirin that causes the bleeding into the brain?
Okay, Madam Elaine, I can see you are very worried. Like what I mentioned earlier, actually, I'm sorry to say, we really couldn't be sure that which whether it's the stroke that causing the blood vessel to be more fragile and to bleed within the stroke area, or is caused purely by the aspirin itself. But um, what we but if we actually go back to the scenario at that time, we will still give the aspirin because aspirin was the correct treatment and given in her best interest at that point. Can you
Okay.
understand me?
Yeah, doctor, can this be aspirin allergy? Because last time also after serving the aspirin, it's very eventful. She have a bleed and then she also unwell. I'm just questioning whether that this aspirin should be given at all for her, you know?
Okay. We actually have gone through all her previous admission notes during the hospital stay. Actually, there was no any documentation about the aspirin allergy. So I think we are quite certain that this is not due to the allergic reaction that causing the bleed in his brain, in her brain.
Oh, so you, doctor, you think this sudden deterioration is due to the progression of the stroke that she have, right? It's not because of infection of her lung or any reason?
Yeah, we think it's actually progression of the stroke in her brain. Actually, it is not uncommon that patient who has a big stroke in their brain develop bleeding in that within that stroke area. It's actually not uncommon to see that. We quite frequently see similar cases during our clinical experience.
Okay, doctor. Then what is the next step, doctor?
Okay. Another thing that I need to, another serious matter that I have to discuss with you is that because from the CT scan, we actually see that the bleeding area has actually shifted the brain matter. So this is a bit complicated, but just let me draw a diagram for you. I will draw. This is a patient. This is a mother brain. So our brain is a very rigid space. So all the stroke and also the bleeding has actually shifted your brain matter, your mother brain's matter to another side of the brain, and this could actually lead to life threatening event. So we after this we will refer your mother to our brain surgeon doctor to co-manage. They will come and assess your mother and have a look at the image CT scans, and we will further decide from there. She might even need a surgery, but it all depends on the decision of the brain surgeon's letter. Can you follow me so far?
Yeah, but sorry, why is gray matter, doctor?
Okay, it's actually it's the brain tissue. Means the brain component in her brain.
Okay, okay. Then do you think that my mother can survive? You know, it looks very pretty bad from what you have drawn and what you have told me.
Yes, Madam Elaine, I'm so sorry to tell you that Madam Susan is in a critical condition, but we will immediately involve our stroke specialist as well as our brain surgeon doctor. They will come and talk to you as soon as possible regarding the further management from here. Um, whether it involves surgery or not, brain surgeon will further discuss with you from here.
Yeah, doctor. Then meanwhile, we're waiting for them. What have you all done to my mother?
Okay, so now we will keep your mother in close
2 minutes
monitoring.
left.
Uh, for temporary leave, well, we have immediately stopped the aspirin, and from here we will further our stroke specialist will further manage uh, by deciding on the suitable timing to restart the aspirin or any other medication which is suitable for your mother. For now, we have already stopped the aspirin to prevent further bleeding, and we
Okay.
also keep your mother in close monitoring. And also, like what you say, because your mother previously has had bleeding from her gut, we will monitor her for this as well.
Okay, doctor. Then I want to know, my mother previously was very well, you know, she was walking without any support at the age of 70. She can take care of herself very well. So are you all going to give up on her if let's say the brain surgeon say no for surgery?
Okay. I'm so sorry that your mother went through all this. Um, okay. All right. So if the brain surgery surgeon doctor say that it's not suitable for operation, then all this after this we will offer there's a treatment called rehabilitation where we will try to improve her motor function and also her swallowing. We will also check her swallowing and also her the whether she can and also her speech. We will try to help as much support as much as we can from there.
Okay. But do you think that she is fit enough to go through all this?
Of course, not at this moment, not at this point of time. For now, I think we will need to stabilize her first because she's still in very critical condition. For those rehabilitation, it will be later when she's out of this critical condition. For now, we will just monitor all her consciousness
Okay,
level,
time's
blood
up.
pressure, and is
Okay,
there
time's
any?
up.
Okay.
All right. Thank you. You may proceed with the next station. Okay, that's the example. Huh? So, how do you feel about your performance, Karen? Is
Actually,
there
I'm not fluent.
I think you are fluent though. I mean, is there anything that you feel is a bit difficult in this scenario?
Actually, I'm not sure like how detailed I should tell about the management because
Mm,
there is nothing written that whether she's going for surgery or not, and I think I'm
yep.
not in the position to comment on this, so it's a bit difficult to elaborate on the management part.
In terms of the management that you can offer, as in, I mean, while waiting for the so-called surgery to be done, like early decompressive connectomy, things like that, you are in an acute stroke unit. I mean, what are the usual thing that you can tell the patient's family members? I mean, we will cerebral protect the patient, right? Definitely.
Mm-hmm.
Yeah, and we also need to control the blood pressure quite aggressively in view of the bleed, right? So all those things is something that you should explain to them while waiting for the neurosurgical consult. And true enough, this scenario didn't mention what is the next step, right? Because it just mentioned subsequent management. So this kind of scenario can be a bit tricky. But this is kind of like a real scenario from one of the mock exam or things like that. But what I can see that this scenario can be quite challenging because it tested you on the clinical judgment in terms of what you're going to offer. Definitely, your clinical judgment will not be full. The reason is being you mentioned about the occupational therapist rehabilitation at this point of time. Because from the CT scan and from the scenario, it seems like very poor prognosis already, right? You're talking about whether patient can, we are not sure whether patient can even survive, you see. So that's why I got some similar kind of scenario when I was attending a Batu Pahat mock. And that time I think the examiner was Christopher Lee. Yeah, the ID consultant got something similar. Then he asked me the same thing as well. Because my one was old format, that there's this Viva session with the examiner. The examiner asked me, so what are the point of you mentioning all those we have, things like that? And patient now is so ill. I really get, I was like, okay, oh, sorry for that. So I think you need to focus because this 10 minutes communication skill is very limited in time. You need to focus what is the most important thing, and you need to just mention about salient thing. The rehabilitation, the swallowing, as well as the physiotherapy, things like that, probably not very important at this stage because this is the stage that you want to explore what is their expectation, and also what is the advance directive if there is any, and also lasting power and attorney. You probably not in detail, but you just need to ask whether have she ever expressed herself if she became unwell one day. What is the thing that she want? Did she express any of her wishes in the past? And then did she appoint anyone to become a decision maker in the event that she cannot make decision? Probably just these two questions is enough. But I mean, generally, you don't know whether you should DNA the patient, you don't know whether you should go active, and you don't know what is the neurosurgical input. So this is a scenario that it opens up the management. There's no right or wrong thing. It's just that we should go, like what you mentioned, I think referral to the neurosurgical team and to do a surgery. So you also need to mention what are the surgery neurosurgical going to do other than just referral. You say that, okay, I need to refer them, seeing that whether any role for them to do a to open up the skull with a small holes, or even a smaller part of the skull, just to relieve the pressure for the brain. And then this will hopefully make the brain less swollen, and then hopefully it will not affect the other major function of the brain, such as the breathing center and also the rhythm center, things like that. Probably you should mention something like that. I mean, yes, neurosurgical referral, totally agreeable. And you should also mention about the acute stroke care, what was done, and then what are the usual thing that was done. Okay. And then you should also explore a bit on the advanced directive. And if you have time, because I'm the one that offer you in terms of the social and the pre-morbid function, this kind of scenario is always important for you to explore the pre-morbid, you know. Pre-morbid as in you should ask before she became unwell, how is she at home? Instead of asking her what are the symptoms when she come to hospital, it seems like you're asking like a history taking. I mean, it can be dangerous, but you don't have to do that. I mean, if the candidate, I mean, if the surrogate just tell you like that, you can just proceed because you go by the scenario. Those are the things that the surrogate already expected to know. So what you are doing is try to see what the surrogate understand instead of like asking history. Like, because I think the initial part, I got a feeling that this may be labeled as taking history from the surrogate. I mean, for the the left-sided body weakness. Okay, but anyway, for in terms of the flow, I think you do okay. It's just that you should explore a bit on the pre-morbid as well as the social before you make a short conclusion within the 10 minutes. So if I'm going to give you the marks, like nowadays I try to put this because I really feel that it's more relevant, especially if you go for exam. So let's say I think your clinical skill is satisfactory. I think your explanation is quite clear, structure, and fluent. Actually, you are fluent, no? You're not stuck. Your concern is also, I mean, you're managing the concern also quite well. Definitely, you can score two here. But your critical judgment, I will only mark you down by one because, like I mentioned, you need to focus the more important thing. There's no point to talk about rehab, swallowing, and speech at this point of time in which the patient is not even stable and deteriorated and may even deteriorated further, require airway protection, which is not mentioned whether the patient was intubated or not. But and then the welfare, I think you can score full. So generally you got two, and then one here. Probably out of the 16 mark, you should able to get like maybe 14 or yeah, I think it should be 14. Unless and that the one of the examiner thinks that it's totally not appropriate, then they may mark you down here, become unsatisfactory, then you may get like 12 marks. But generally, I think you are okay. It's just that you can see that for the com skill, you really need to think what is the most important thing when you have a 4 or 5 minutes outside when you prepare this scenario, especially a scenario that don't have a definite thing for you to counsel, like just to explore and then subsequent management plan. So you need to be very smart in terms of commenting yourself. You can mention the general approach, like what you mentioned is correct. You mentioned that refer to neurosurgical and see what they say, but you also need to kind of like explaining what are the reason you want to refer to them instead of see whether any surgery can be done. You need to explain what is briefly what they are going to do. And another thing is probably not so deep. That's why it's important to explore about pre-morbid as well as the social history. I think if you include that, it should be a very short and sweet 10 minutes com skill. Okay, is there any question from you?
No, thank you.
Yeah, you understand, right? Anyone have any question before we proceed to the next case? Yeah, just I think I made some notes as well. I mean, just for this is something that I draft sometimes. So sometimes you need to give some time when you introduce, identify the surrogate, and then explain your agenda, explore about the idea or the understanding, and then sometimes you may need to give some time to explore the emotion lah. This scenario actually, the real one actually, the surrogate can be very ganas lah. But I think I don't want to be that fierce. That's why. But you have to remember, yeah, you need to give some time to address the emotion that the surrogate experience. Oh? And then the issue mainly brought up by this scenario is whether or not the aspirin causing bleeding, and then also query in terms of the allergy, and then what is the possible cause of deterioration? Can it be like bleeding or infection, or this is just like what you mentioned, can be progression of the stroke? And then what are because the patient having a poor conscious level now, the thing you need to explore is a brief idea, just a brief idea of advanced directive. Whether or not chest compression intubation to me is optional because I don't think we have much time to focus on that. And in terms of prognosis, you should really mention about what is the thing that may happen if deteriorated further. I think mainly is the disability and the death that you need to focusing on, and therefore you will bring to the subject of asking in terms of the advanced directive. Okay, you need to prime them that this stroke is very massive and it can cost her life. If it doesn't cost her life, also it may lead to very severe disability. Okay, and therefore it's important for you to explore the advanced directive. So the management, the acute stroke care, you should mention about close monitoring, medication to reduce the pressure. Sometimes we even give the mannitol, right? And then medication to reduce pressure, and then BP control, some medication and nutrition. You can mention just like that briefly. No need to mention it in detail. And then neurosurgeon referral that I mentioned, and then explore about the support and social history as well as be morbid. And then if you got time, then you should do a summary, a simple, maybe 10-second summary, offer some information, leaflets, and also hospital contact number if any further question. Okay. So yeah, Jonathan asked a question. How do we answer the part that are you going to give up on her if the neurosurgical team does not go for op? Or did the aspirin cause the bleed? So we probably to answer the aspirin cause the bleed, no. I I agree with Karen because aspirin to give aspirin in a massive stroke is the correct management, huh? And sometimes I mean for the minor stroke, sometimes we will give a double antipellets, but for major stroke, sometimes we only give a single antipellet and we really observe. So this is actually a correct management. Okay, it is not a medical error. What kind of scenario this can potentially turn into medical error? Let's say that this aspirin is continue and not stop, and patient did a CT brain and noted got bleed already, but this medication still continue, then yes, this is definitely a medical error. But for this scenario, this is not a medical error. In fact, I mean, this scenario was stimulated in a real exam, and in fact, one of the question the surrogate also asked the same: is it because of aspirin that causing the bleed? Is it the cause why the brain have bleeding? And then I remember the answer that they give also no. It's because of the stroke progression. It's a massive stroke. If you're predisposed to bleeding, okay. And the second part is, are you going to give up on her if the neurosurgical team does not go for op? Definitely, we don't talk about. I mean, if the surrogate asks like what I asked, then you should say that. And I think it's a bit premature for us to tell about her condition. But generally, if the neurosurgical thinks that there is no benefit to go in for surgery, unfortunately, I'm sorry to tell you that her outcome may not be good, and she may continue to be deteriorated, and this may really lead to death. Okay, and if she may not to manage to survive, she may also have or severe kind of or permanent kind of disability. So we need to prime that as well. Okay. But generally we don't give patient up. I mean, what is the meaning? Let's say you are worried to answer this kind of question. Probably you should ask the surrogate. Sorry, what you mean by giving up? Yeah, you should ask to clarify because giving up can mean a lot of things, right? Giving up can means DNAR, giving up may means comfort care, and then or supportive care. So generally for stroke, this kind of patient, we should go for supportive care unless the condition deteriorated further and there's no role for us to do anything other than comfort care. Then probably that time, then we should counsel more towards the comfort care. But at the moment, definitely it's a supportive care because she just deteriorated and then this thing just happened. And then this is like the first consultation, like with the family members to explain about her deterioration. So if you're worried to say that if you don't want to say that no, I'm not going to give up on her, we will see her progress how it goes in the next few days, and we will definitely update you from time to time. uh, we also monitoring her closely, and we will see what is the next step, and I'll definitely arrange a subsequent session with you. Would that be okay? So sometimes you don't have to answer the question. I mean, they ask a concern, but to address that concern, you don't need to give a very definite answer at times. What you can do is sometimes things can change. So you see that probably we will observe and then we will see what we can do, even if the surgery is not really indicated and neurosurgical team don't think we have carry any benefit, we can still support her. However, you have to understand the complication that can occur from this severe stroke. You can just mention like that. Okay. Hope that answer your question, Jonathan. Okay, next we should go to the second scenario. I think the second one is Yi Hong, right? Yi Hong, are you there?
Hello, yeah.
Yeah. Can you hear me?
Yep.
Yeah, but I think your voice there is a bit soft. Yeah, probably can put closer to the mic. Is it okay?
Yeah, yeah.
Okay, so we'll give you 4 minutes as well. Your time start now.
Okay.
Okay, 4 minutes up. Let's start.
Hello.
Hello.
Yeah.
Yeah.
Hi. Good evening. May I confirm that this is Mr. Arumugan, 45 years old?
Hi. Yes, I'm Rumagan.
Yeah, I'm Dr. Lee here, one of the doctors in the lung clinic. So today we would like to discuss about your health condition. Would that be all right?
Oh yeah, sure.
All right, Mr. Arumugan, before I start, would you like anyone else to be with you during this consultation?
No, no, I'm fine.
All right. So, Mr. Arumugan, may I know what have you know so far about your health condition?
Yeah, doctor, I've been a very active person. I do a lot of sports and also regular exercise. However, for the past 6 months, I'm been having breathlessness, especially when I exert myself. And also, I have this very dry cough for intermittently. I don't know what is the cause. So I was investigated in the last appointment with the X-ray, and then the doctor told me got some whitish spot seen in the X-ray, and then already done the CT scan. And today also I've done some lung function tests. So I'm yet to know what is the result.
All right. So, I see. Mr. Arumugan, it must be quite difficult for you for the past 6 months having all the cough. So, let's see how we can help you with that. So, basically, your CT result is with me, and also the lung function test result is with me as well. So,
Mm-hmm.
I also have all the blood investigation. So, unfortunately, I would like to inform you that you has been diagnosed after discussion with our consultant. We would like to diagnose you as a condition called interstitial lung disease. Have you actually heard of the term of interstitial lung disease?
No, what is that, doctor? It sounds
All right.
scary to me.
All right. So let me explain to you what is this interstitial lung disease. Basically, it means that the body defense system is misdirected and also is attacking your own body, causing the lung tissue to be hardened, causing hardening of the lung tissue. In medical term is called fibrosis. So therefore, when the lung tissue is hardened, you will experience a symptom of worsening shortness of breath and also the dry cough that you are actually having. Right.
Okay. Is this something permanent, doctor?
All right. Unfortunately, once the fibrosis or the hardening started, it is irreversible. We cannot actually return the hardened tissue to be a normal tissue. What we can do is to stop or slow the progression of the disease. Okay, to stop
Okay.
and slow the progression of the hardening. All right. So, how can we do that? Is through several treatment, in which I will discuss with you shortly. And um, one thing that I have to be honest with you is that there are several complications that can actually follows if this disease is not treated properly. All right.
Mm-hmm.
Even
What,
if we treat with the
what kind of
medication.
complication, doctor?
All right. So when the lung tissue is hardened, as mentioned just now, you will have when it progressively harden, you have more difficulty in breathing, and also your symptoms might actually get worse of the dry cough and also shortness of breath. And
Mm.
also because the tissue is something that is unhealthy, it is easier for you to get into a very serious lung infection, causing you to have a very bad infection or a lung infection that can be actually detrimental and also severe enough, which can lead to difficulty in breathing, needing help with help with breathing using a machine. That's number one. And if the hardening persists, so when the lung tissue become totally hardened, you might also have even breathlessness when you are actually not doing anything, requiring you to wear an oxygen at home. All right.
Okay.
So all that also can affect your heart function because your heart and your lung is closely related. It can also cause weakness and also cause dysfunction of your heart, leading to your heart beat is getting weaker and also your heart pumping function is getting weaker, what we call as heart failure. So it can lead to a lot of complication if it's not treated properly and also timely. All right.
Okay.
All right. So, so far, do you have any question and can you follow me?
Yeah, I can follow. I'm just wondering what options available for me.
All right. So, the most important treatment that we after discussion that we would like to start you on is actually a steroid therapy, in which we would like to stop the inflammation or the hardening that is going on. So, have you ever heard of this medication called prednisolone?
Yeah, yeah, I know it's a steroid. I also very scared. Why do I need to take this steroid?
Okay, basically, like I mentioned just now, it is because of your body the immune system has been overactive and misdirected and misaligned and attacking your own body. So it is important for us to suppress this overactive of this immune system. So steroid is a very good medication in terms of suppressing the in your own body immune system. Of course, there comes with certain effects and also risk. But given that the condition is your CTs and also your lung function test, everything is very suggestive of this interstitial lung disease. It is very important for us to start you on a high dose of prednisolone, and subsequently we will reduce the dose according to the response and also according to the your condition. All right.
Doctor, if I don't, what will happen if I take this steroid for a long time?
All right. So that's the next agenda that I would like to discuss with you. So steroid, the possible side effect that can follows when you are actually taking a high dose steroid. Number one could be a high blood pressure, difficult to control blood pressure. You can actually also can have diabetes or high sugar level. So these are the common possible side effect that can follows with long-term steroid consumption. Of course, other possible side effect includes thinning of your bone, what we call as osteoporosis, and some of the patient might actually experience stomach discomfort of gastritis because of the steroid. So how do we counteract with all these possible side effect is that when we start patient on high dose steroid, we will actually supplement with calcium and also vitamin D to prevent thinning of the bone. Then also we will supplement with gastric medication to prevent symptoms of gastritis. Of course, we will follow up with your blood pressure monitoring and also your sugar monitoring to make sure that your sugar level and also your blood pressure is under good control as well.
Mm-hmm.
All right. So other possible side effects also sometimes patient might have a thinning of the skin and also might have acne as well, what we call pimples. So for this we can also give other medication and also a skin lotion or to apply for you to apply. All right.
Doctor, you have mentioned that my lung potentially can get infection easier. Won't if this medication started, I will get more infection?
Yeah. Therefore, actually, for all patients with this lung problem, what we call as interstitial lung disease, we will actually offer patient for vaccination to the common bacteria and also viruses that can cause infection.
Two
So
minutes left.
usually we will offer for vaccination to the influenza virus and also pneumococcal, one of the bacteria that commonly can get. So usually after we vaccinate the patient, it is lesser chance for you to get the infection.
Okay,
All right.
doctor, if I don't agree to take this prednisolone, is there any other options?
Yes, there are other option which is medication called steroid sparing medication. It basically means that it will also suppress your immune system, but it will take times for the medication to work. So usually we will start the patient on high dose of steroid. Subsequently, we will introduce this second medication and we will slowly reduce the steroid that you are actually taking.
Okay.
All right. So, do you have any other concern that you would like to ask?
No, doctor.
All right. So, Mr. Arumugan, may I just ask, do you smoke?
No, no, I don't smoke.
All right. So, because smoking also can actually worsen the condition. So, other therapies that we can actually offer is that besides the medication and also vaccination, we will refer you to the chest physio for regular physio and also regular follow up to
Okay.
with the, and also we can actually refer you to the rehab team for
Mm.
what we call as a lung rehab. All
Mm.
right. So, do you have any other question that you would like to ask me?
No.
All right. So, in summary, basically, Mr.
Okay.
Arun.
Time's up. Time's up.
All
Okay.
right.
All right.
All right.
Okay. How do you think about your performance?
Okay. Good.
Okay.
Okay.
All
Good.
right. Yeah, but I think actually you are very fluent. The problem with you is I notice very lengthy answer and explanation. Perhaps you should make it more simplified and more concise. It's also easier for the examiner and the surrogate to listen. So you have because your sentence tend to be very long and lengthy,
Mm.
and you use a lot of words to explain uh something when you go through, so it will be quite lengthy. So my only question to you is, have you gotten any consent from the patient to start prednisolone or not?
Yeah. Not yet. Actually,
Not
towards.
yet, but summarize already. Oh.
Yeah. Not yet.
Yeah. So you didn't take the verbal consent, right? You didn't explore whether patient. So are you agreeable to try with this medication?
Mm.
So I think to me, if I'm going to choose like 10 seconds to do either summary or consent, I will go for consent. Oh, summary
Uh,
is not that important. Okay. But generally I think you are okay. The scenario actually lung thicken, I mean you use the term hardening of the lung, right? Is there any better word for lung fibrosis in a layman's term?
uh, thickening.
Yeah, thickening, okay. But thickening can be bronchitis also, right?
Yeah.
How about scarring?
Oh, okay. Yeah.
Yeah,
Lungs.
usually usually for any lung fibrosis we use the term scarring, huh?
Mm.
Scarring. But you did mention something that I'm not very agreeable.
Mm.
You mentioned that if the lung tissue that is already become thickened already cannot do anything, and the role of medication to reduce the damage and the insult to the remaining healthy tissue. But this patient is actually having NSIP. Do you think it's possibly can be reversed?
I think NSIP is still okay. It's not as bad as UIP.
Yeah, we know UIP is definitely irreversible, huh?
Mm.
But NSIP is something like organizing pneumonia, or in fact, I would say better prognosis of organizing pneumonia, and therefore, actually, you should mention that there is a chance that it can be reversed.
Oh,
Okay, but the way you tell is like there's no chance that those thickened tissue will I mean those hardened tissue will not be recovered. And your role of steroid is just to prevent the progression. Some
mm.
people they do really well when they repeat CT after started on trial of prednisolone. The the lung parenchyma actually resolve. Some of them very well respond. So that's why for you when you counsel, perhaps you don't have to be so committed saying that those thickened tissue is irreversible. But of course you can mention that under the complication without treatment, you say they will become permanently scar, and those permanent scar tissue will not be able to help with the breathing, and you may get breathlessness easily. Okay,
Mm.
and you have mentioned, actually you have covered pretty much all the points. Perhaps the only thing that you didn't mention is the consent, which I think is important. So if you're going to mark you communication skill, I think it's fine. Got satisfactory. Concern you also address very well. Your clinical judgment, probably I will mark down you just borderline because you didn't explore the patient idea of taking the prednisolone, whether agreeable or not. Okay.
Oh,
And then the welfare part is definitely not an issue. Okay. So
mm.
definitely you also got like 14 marks out of 16 lah,
Yeah.
roughly. Okay. You have any question for this scenario?
Not really.
Not really, like. And then
Yeah.
anyone else got any question? Or if not, I will just proceed to discuss first. So usually when I prepare this kind of scenario outside, what I will usually write is perhaps just these few words as my framework, because we only have 5 minutes. We don't really have time to write a lot of things. So you need to decide what are the things that you must go with your framework. So perhaps if I don't write also, I will write something like define cause, symptom, complication, and then the management. So you can see that Yi Hong is very good because in his mind, he already decided how he's going to carry out. Just now when I actually intercept him and talk about complication, right? And then he suddenly remembered to talk about the management. Okay. And he did not review the management at first until I asked further. But you can see that he covered pretty much a lot of things. Okay, pulmonary rehabilitation vaccination in this scenario is a must lah, for any chronic lung diseases. We should mention that. And also those medications, symptomatic relief or the cough secretion also can be mentioned. Okay, and I think the main important point is the irreversible scarring and causing severe disability requiring oxygen support. And these are the one that we can use to really counsel them for trial of this steroid. And usually when we counsel for steroid, you should mention the indication, some detail. Let's say you know if it's not mentioned, but in this scenario, you know that you're going to start with high dose and subsequently taper down. Okay, depending on the progress. Probably by weekly, usually 5 mg per week, but don't have to tell that because it's not mentioned in scenario. You just mention for we're going to taper from high dose to a low dose with time and see your response. Okay, and some of the side effects, steroid is very important for us to counsel. And I think Yihong did not have enough time to talk about precaution while on steroid, right? But you did mention a bit overlap. Later we will go through. And the consent is something that you must always write in your paper, or else we will definitely forget. And if you really, really have time, then you can talk about smoking and also occupation. I think Yihong explored about smoking and then the activity limitation. Oh, it's always good to check back the patient that I can see you are you're having a lot of symptoms. May I know that if all these symptoms are affecting your daily activity living, then they will tell you a bit. It's always good to check back. I mean, those international examiners, they like to hear this. They like to know what are the problem that the patient have that can affect their daily activity life. Those are the things that is quite important to them. Okay. And then concern, we clarify what are the other concern, and then summary, it's just like the usual one. So usually outside, perhaps I will just write explain ILD, explain steroid, and then ILD I will branch into define cause, symptom, complication management. And then some of the things that I think I may forgot to mention, I will write down. And then subsequently the steroid, I will write down like this kind of template also, but I won't write anything other than that because to know, I mean, we always need to be prepared for scenario of counseling in terms of starting medication, especially steroid. A lot of condition need steroid, no? So just to go back, the side effect is important because you need to counsel them what are the potential side effects. You can say that there are some common or some serious side effects that you need to be aware. Common one will be those irritation of the stomach, can feel a bit sick or bloating. And then Yeho mentioned about diabetes, also mentioned about the weight gain as well, because their appetite will generally increase. Same goes to their weight, and then may need monitoring or adjust the medication. And then the high blood pressure may require some medication to control thinning of the bone and the risk of fracture. He mentioned that as well, osteoporosis. For that reason, we will give you some calcium and also some supplements like vitamin D. And then if let's say further therapy is needed, then we may need to start you another medication to reduce the risk of fracture if you got time. But I think to stop at calcium and vitamin D is good enough. And then risk of infection is also very important to advise them that because you're prone to infection, you will need to really practice a good hygiene and wear mask in the public area, okay, and cook a very consume a cooked food. And then cataract and other thing is not that very important, but if you got time, just good to mention. Okay, so these are the serious side effects that you will need to be aware. And the precaution is mainly the infection part that we need to advise them because we are giving high dose steroid. High dose steroid is really at risk to get infection. Okay, all right. Anyone have any question before we proceed with the next candidate? Okay, no question, yeah. So the next candidate is going to be Joyce. Joyce, are you there? Hello, Joyce? Can you unmute yourself?
Yes.
Okay, all right, sure.
Hello,
Okay,
yes.
so
Yes.
yeah, I can hear you. Are you ready? Hello, are you ready?
Yes.
Okay, all right.
Yes.
So I will give you 4 minutes, and then your time will start with my timer is not ready. Okay, your time will start now. Okay, 4 minutes is up. Are you ready, Dr. Joyce? Hello? Hello? Hello, Joyce, are you ready? Hello?
Okay.
All right, okay, let's start. Your time start now.
Good evening.
Mm-hmm.
Me?
Sorry, your audio is not very clear.
Hello?
Hello, yes? Okay, we start.
Hello?
Yes, okay, we can hear you.
Hello?
Yeah, we can hear you.
Hello?
Maybe your audio got some problem, but we can hear you clearly, loud and clear.
Hello, good evening. Can you hear me?
Yes, yes, we can hear you. Yeah, probably I'll pause the
Okay,
timer.
okay.
Are you okay? Do you able to hear our my voice?
Okay, good evening. I'm Dr. Joyce, doctor in charge in the respiratory ward. May I know I'm next of kin of Mr. Razak by.
Yeah, I'm his daughter. Mr. Raja is my father.
Okay,
Hello?
hi, Mr. Husna. So
Mm.
today we're gonna hello. So today we're gonna talk about your father's condition. And
Mm-hmm.
before I start this conversation, do you want anyone to be with you?
No, no, no.
Okay. So before we start the discussion, may I know how much you know about your father's condition?
Yeah, my father has a fall about 3 months ago from a chair, and subsequently he cannot move, and therefore we sent him to the hospital, and then we are told that he had a fracture over his back, and they did the MRI. They told us that they found something, some lesion at the right upper side of of his lung, and then they told me of the
Mm.
possibility of maybe this is something cancerous and that may be already spread to the bone. We are aware about this, and but our main concern now is that he has not been mobilizing at home, and he has been complaining a lot of pain, especially the back, and this really caused him a lot of issues. He is not eating well as what he used to be, and he cannot sleep at night, and he really feel very troublesome for him. We hope that we can bring him to the hospital and try to offer something for him. Mhm.
Okay. I know that it must be very distressing for you. Currently, may I know what is your expectation?
Yeah, my expectation is that I hope his pain can be controlled well and he will feel comfortable.
Okay, so regarding the pain, for now we are giving him our painkiller medication, which we call it morphine. We are giving him regular morphine with some add-on if required, and of course, we will co-manage with the palliative team regarding the pain management.
Sorry, doctor,
And
what is palliative team?
oh, okay. Sorry. So palliative team is a team that help to take care of patients who are in advanced stage of disease, which is like your father is in a very advanced stage of cancer. And the main goal of this team is to provide comfort care and to reduce suffering for your father.
Okay. You already refer to them?
Initial so before that we will try to manage his pain control first
Mm-hmm.
by giving him morphine and other medications and to make him comfortable. And regarding his distress and unable to sleep, we also will provide him some sleeping pill so that he can take a good rest.
Mm. Okay.
And because now I realized that he had a lung mass just incidentally noted, And so we will investigate further whether this is by I will refer him to a chest doctor to take a biopsy from the lung to confirm whether this is a cancer, is a benign or is a malignant cancer.
Oh, doctor, but I thought you are the doctor in this chest ward.
Yeah. I will discuss further with my consultant regarding his management plan. So because it's just a first time noted that there's a mass over the upper part of the lung, and it might be a primary cancer, means originate from the lung, or it might be from somewhere else. So to confirm that, we will need to take a sample from the lung to find out whether this is a benign or cancerous mass. And we also need to arrange for him a CT scan to screen the other part of the body, whether there's any mass as well or any abnormality.
Oh, okay. Doctor, is the biopsy really necessary?
Yes, because so that we can know what is causing him to suffering from the spine fracture. Probably is a spread from the cancer to the bone.
Doctor, this fracture of the bone cannot be due to old age. Like what I heard about osteoporosis. Can it be due to old age instead of cancer because of some other place?
It is possible to be due to old age as well, but because we need to find it can be multifactorial, not only the spread of the cancer, but what we need to tackle now is why there is a mass over the lung. So that's why we would recommend to do a sample, take a sample from the lung to confirm the diagnosis.
Oh, okay. Then how about this spine fracture? Anything can be done? Because I mean, I understand that you're giving painkillers, but the thing is he's not able to move at all. He's only bed bound. Is there anything can be done in terms of this fracture?
For the spine fracture, for now what we can do is to reduce his pain by giving him the painkiller, and beside that, we will need to immobilize him for this moment because we are worried that it might dislocate and causing nerve compression. And I will also refer him to our orthopedic surgeon to further manage on whether this spine need further surgery.
Surgery, okay. Oh, I mean, what kind of surgery you're talking about, doctor?
Like any instrumental that may help it to prevent the spine from dislodging and compressing on the nerve.
Okay, all right. Doctor, you have mentioned about this biopsy, right? Sampling of the tissue. You have mentioned that it's necessary to perform. But what is going to be the next step? Let's say this is turned out to be cancer.
Okay, so if it's turned out to be cancer, then then we will and if already confirmed spread to the other parts of the body, this is considered last stage or advanced cancer, then I will refer you to the palliative team, which is they are expertise in providing taking care patients who are in advanced stage of disease, and the main goal of treatment is to provide comfort care and to help to reduce the suffering of the patient.
Does that mean that if it's stage 4, there's no role to go for any, chemotherapy or any medication anymore? 2 minutes left.
I will discuss this with my consultant regarding the chemotherapy.
Oh, okay.
And also further care.
Doctor, you had been telling me that this can be cancerous, right? Is it okay if you please don't tell him about this diagnosis? I don't want him to know, no?
Okay. Okay. Actually, this is the patient have the right to know what he's having, what his condition is, and of course, I know that you are worried about your father. You will be very distressed when he find out his condition. But is my advice is we need to let the patient know so that he can understand more about his condition, and we can provide support both to the patient and also to the family.
Oh, okay. I really don't want him to suffer, you know. Is there anything else that we can do to help other than this pain medication, you know?
Hello.
Yeah. Is there anything else that you can offer us? I know that you're going to refer him to the palliative team, but other than that, is there anything that you can help with just other than this pain control?
I will also I will also refer him maybe just he is having a lot of distress. I will refer him to the uh, psychiatry to help so that he can provide more emotion support. I don't know.
Okay. Okay. All right. Okay. Time's up. Okay. That's all. I'm just going to pause the recording. You are Joyce, right?
Is there any?
Yeah. Time's up already. Time's up. Time's up. Yeah. How do you feel about your performance?
Yeah. I know I did very bad.
Hmm. I don't know whether because of the audio issue or it's more like you are having issue in terms of answering the concern lah. Huh? But
I have problem
sorry,
hearing from the audio. I have problem hearing from the audio.
I see. Is the audio is very muffled?
Yeah.
Okay, all right. So, but anyway, I think you have tried your best. But what is your comment? I know you say that you performed badly, but what is your comment on your own performance? Just more like in the technical aspect.
Maybe I shouldn't reintroduce palliative care too early because I don't even find out what is the primary cause
Yeah.
mass which is noted in CT.
Is there anything else that you want to comment as well?
Mm,
How about the role of doing biopsy and also the role of surgery in terms of the spinal, the fracture?
you mean the spine fracture?
You have mentioned that you're referring to the orthopedic doctors for potential role of surgery to fix the spine, right?
Mm.
What is the idea of doing this?
Actually, it depends what type of where is the spine fracture and whether there's any nerve compression or not.
But he already not able to move for the past 3 months bedbound lah. Do you think that is it a good options for any form of surgery?
No.
How about the CT? I mean the so-called the biopsy of the lung tissue. Will it change any management?
Yes, because actually we don't know what is causing. It's just a suspicious of the bone mass, and I think it's important to know whether that the primary source is in the lung or not.
Okay.
And find out what type of cancer is it to prognosticate.
So before answer this question, then the one of first question that the surrogate asked was, can this be just fracture from the OH instead of fracture of the spine? I mean, or fracture for this cancer related weakening of the bone. And you answer that can be multifactorial, can be both, right? Do you think it's possible be just osteoporosis fracture?
Yes.
But it's a very low trauma kind of fracture, right? In the age of 65 years old, men.
Mm.
Yeah.
Yeah.
So actually less likely because this fall is a low energy impact kind of fracture, fall from the chair to the ground, and at the age of 65 in the men, less likely to be osteoporosis, right? I mean, it's a
Mm.
spine fracture. Spine fracture is it can be osteoporotic in to begin with, but we won't know. I mean, unless the scenario mentioned. But you can see that the way the MRI commented is actually with bone metastasis, suggestive advanced malignancy in bone metastasis. So other than fracture, I'm sure that the MRI must have telling other features in which the report can be mentioned as bone metastasis. Because generally, if pathological fracture of spine, if 1 or 2 level, then it's just fracture, right? But let's say there is something else that they see, that's how they usually comment bone metastasis. No? And
Mm.
and this kind of scenario is a bit tricky. You don't know where is the primary. Agree with you. Whether any role of CT guided, doing any CT guided or bronchoscopic guided biopsy to identify the lesion of the lung, it is questionable. But the problem I realized from your consultation or your communication is that you did not explore the idea from this surrogate at all. What do you think about this? You did not clarify with them. Basically, what happened is that you explain everything in detail and you explain what are the options, but you actually did not ask the surrogate what they think about this, what they think about this. Do you think uh, this is a good approach? Do you think that you should proceed with this? So always check back with the surrogate, you know. Don't just offer, because I realized that first of all you mentioned palliative care a bit too fast, a bit too prematurely.
Mm.
After
Mm.
just right after pain control, regular morphine, you should even mention about palliative care. That's a bit premature, I would say. But you specifically also realize that you did that a bit too early. That's why you tale balik about, and then you mention other things. But I think it's not easy scenario, I would say, because the scenario did not mention what is the management you are expected to mention. Oh, the
Mm.
scenario just tests you on the management that you should offer, and therefore it's tricky. This kind of scenario, if come out, you should really explain regarding there are 3 things that you need to explore. First thing is the right lung mass. Second thing is the this bone I mean the spine fracture. And the third thing is actually the advance directive. I did not hear anything about advance directive from you from this scenario. Even with or without cancer, regardless where's the primary, this is advanced cancer already. So you should really explore the advanced directive and also the lasting pulmonary autonomy, and also explore about the role of no active resus for this patient, because it's more important to actually know what is their idea first. So I will split the discussion into these 3 parts mainly. Regarding the right lung mass, I will mention to them that in order to know what exactly types of this cancer and what this cancer originated from, and whether this is really a cancerous instead of just benign mass, we ideally should go for this sampling of the tissue, or we call biopsy. Okay. However, it really depends on whether or not it will change in terms of the management. So at this point of time, you should really explore what is their idea on doing this. Let's say this mass turn out to be cancerous. Um, would would the family members or the patient agreeable to proceed with chemotherapy or even some form of medication therapy that can also potentially carry a lot of side effects, such as vomiting, such as reduced appetite, or even feeling weak to even go through the completion of this medication. So this actually have to really ask them again. Because if eventually they refuse everything, then what is the role of doing the biopsy, causing unnecessary pain and the risk of the biopsy itself, like pneumothorax, leaking of the air into the space, causing the lung to be to collapse, and also the risk of infection, introducing infection, and also the risk of bleeding. So it always carries a risk to do something, and the indication is there. So therefore, I think when if you want to talk about this right upper loop mass biopsy point, I would actually tell them these 2 directions. The indication is there and the side effect is there. And what is the next step if this turn out to be cancerous? So we will explore the idea from them. If you ask me this way, I would say that no, I think my father is too weak to go through this kind of procedure like chemotherapy. We will not want him to go through all this. If the surrogate mentioned to you like that, then definitely you don't have to, I mean, stressfully counsel for biopsy, because eventually if it does not change the management, then maybe there's no role. Okay, and the second idea is regarding the spinal fracture. You have mentioned that pain control is one. Second thing is about the immobilization of the spine. But how to immobilize when he is in so much pain? He's going to be immobilized, right? And your role is to prevent the fracture to getting worse, right? So yes, I mean you talk about surgery, but probably surgery will not be a you can mention, but you can also mention that surgery may not able to benefit much. However, it's best to let the bone doctor to talk to you all to understand in detail. In a certain circumstances, if surgery cannot be done, there is also a possibility of getting a brace to really stabilize the spine and prevent further fracture. Okay, and regarding the idea on the outcome, really have to explore the advanced directive and the lasting power of Adoni, as well as explore the role of active resuscitation. Okay, so it's a bit difficult for this scenario because there's three things that you need to do, and to do it well, you also need to explore a bit on the patient morbid and also the social support. So definitely it's not a very simple scenario to do under 10 minutes, which I personally feel. Okay, and another thing to point out is that not all lung cancer stage 4 is comfort care. We are dealing with a lot of this stage 4 lung cancer, metastatic non-squamous cell or squamous cell lung cancer. We still can offer palliative chemotherapy. It's not to say that you cannot offer anything, but it goes down to the fact of the patient baseline performance score, ECOG score. If you see this kind of patient with this kind of scenario, you can tell you that immobilized almost more than 50% of the time at home is already ECOG 4 to begin with. ECOG 4 definitely not a good candidate to go for any form of invasive therapy. But it's always good to offer and see what is their idea. I think the reason why you feel it's very difficult and you feel you didn't do well in this scenario is because you feel the resistance you don't know which direction to counsel, and you and when you counsel about advanced directive, the next part is the palliative care that you're already bringing in picture. I think the palliative care you explain a bit on what it is, but it's always good to always phrase this palliative care as a form of multidisciplinary team approach in which will involve a pain doctors, a palliative specialist team, or even specialist nurse, as well as some therapists as well. So their main goal is not to treat the disease, but targeting symptom control. Okay, aiming for pain-free, aiming for any distressing symptom, so that a patient can be put in a very comfortable state. Okay, so I think that's the important point of counseling about this palliative part. Okay, so do you have any question before I proceed with the discussion on the framework? Hello, any
No.
question? Not really. So if I'm going to mark you, yeah, definitely this is just a practice. So don't feel very hard. I think your communication skill will be borderline because not because of this delay or this audio issue, but because I can see that you are jumping here and there. It's not very structured. So it's perhaps for me it's just borderline. And in terms of the concern, I may also give you borderline because you are not empathic enough in this scenario. You should really check back the patient understanding, always confirm. You can see that the marking scheme, it mentioned confirm patient relative knowledge and understanding. You did not confirm. What you do is you just tell everything, and therefore it doesn't seem empathic. And in terms of critical judgment, I would say I would put at borderline or even unsatisfactory, because in terms of the management, it really comes down to what the family member wants. And in regards to questioning the concern of the family members don't want the patient to know the diagnosis, yes, you should mention that every patient have a right to know about his or her condition. That includes your father, and we will really advise you to disclose this, as we as a team will try to help him. And you and family members also need to be aware if he regarding his decision, because if he's still able to make his own decision, we should respect his decision as well. So you can try to counsel that. But and the clinical judgment, the reason I brought down your mark is because in terms of the biopsy and in terms of the fracture and the surgery, I think you need to do it a bit more sensitive way and to explore a bit more instead of telling everything options to the family members. It can be very confusing for them to understand. But maintaining welfare, I think you will get satisfactory. Usually for com skill, if you do it not good, like if you underperform or you do some grave mistake, usually you will get everything unsatisfactory other than welfare. Welfare usually they will still give us mark lah. So probably like 16 marks in total for 2 examiner, you only get like 4 marks. That's what happened to me in my real exam. I only got 4 marks out of 16 marks. And that is because I mentioned wrongly about a very grave thing that I did is when I counsel about poor prognosis, when I counsel about end of life care and the patient decision, I mentioned a very what we call as forbidden words. I used the term vegetable. I didn't even realize that until I request the feedback form. I look at how come my communication station is so badly performed. I really don't understand until I saw that, oh, I actually mentioned that out of stress or no. Sometimes when we do a station, we didn't realize what are the words that we used to or we choose. So we should never do that. When I saw the vegetable say, I was like, okay, I think I will also mark down myself also. Yeah, but luckily I passed. Luckily the other station is almost perfect, only this com skill. But you can see that the choice of word that we use is very important. We shouldn't threaten, some examiner will treat the way I mentioned is like threatening the patient, not given a choice, not empathy, not listening, not confirming understanding. Oh, you see, everything they comment, you know that the mark is going to be unsatisfactory for everything. Okay, it's very personal. Both examiner can be very personal. So it's important for us to choose our choice of word. And especially for your case, also I realized you tend to use a lot of jargons. Perhaps it's not intentional, but things like, for example, orthopedic. Yeah, in UK or in a more well-developed country, it's no problem to use the orthopedic. But I usually try generally to just use a very simple term. I refer to the bone doctor. I refer back to my consultant that's specialized in lung diseases. I will try not to use jargon or use a more specific term because sometimes I realize that, and also you mentioned about benign and malignant. Okay, you can mention it's cancerous or it can be non-cancerous, for example. Okay, if you want to avoid those jargon, a lot of things we may not think is jargon, but to examiner, to some certain extent, they may think this is jargon. If they think you are using jargon, then definitely in terms of clinical communication skill, they're going to mark you down. Okay, try to avoid using any form of jargon. Try to just speak in a very, very normal, simple English, and then you will feel safe. Okay, all right. So just some discussion. If I'm going to discuss for this patient, I'm going to write something like that in my paper when I scratch the scenario. I just explain about this condition in terms of the symptom, complication, and the management. Okay, I will just split by that. If you have a framework when you discuss about any form of scenario, you will not tend to sway away easily, even if patient or the surrogate asks you different question at different time. Because the thing I realized about you is that I cannot feel you are having any template or any framework in your mind. You basically just go with what the surrogate asks and you answer Q&A session, no? But you cannot do it in the Q&A session because a lot of times you need to explain or discuss a certain point that the surrogate didn't mention. A good example for this scenario is I did not ask anything about the end of life care. I did not ask anything about resuscitation. So because I didn't ask, you also did not discuss. But it's important for this case to really explore the advance directive, the living will, okay, and to really explore the idea of the resuscitation, and then only then you introduce the palliative care. If you got time, yes, social history should come into picture, and then any concern and the follow-up. There's a lot of things to follow up for this patient that's impossible to do it in the same setting. One of it is actually the advanced care planning and the end of life arrangement. So this is a bit too much to be covered by this 10 minutes thing. Therefore, you need to focus your discussion at the symptom control, the management, the advanced directive, as well as the resuscitation and the palliative care. I think our discussion stop at here is just good enough for 10 minutes. Other than this one, and if you think that your time is short, it's always good that you tell the surrogate that I think there's a lot of things to be discussed. I can see that you are a bit overwhelmed as well, but generally, please don't be bothered by a lot of things that we discussed. We can always arrange another session to address any other issue or concern that you have. And another thing I suddenly realized is that when a scenario mentioned that a surrogate is a family member or next of kin or someone, you don't have to get the permission from that next of kin, because ideally it is assumed, or it perhaps it is considered accepted from the RCP, is that when you talk to a surrogate, the surrogate already allowed, I mean, the patient already given consent to the surrogate to talk to you. This is by default if they ask you to talk to a surrogate. So therefore, a surrogate cannot have a right to say they can invite another person to into this discussion, because the another person may not got the consent from the patient to speak to you. So that's why it's important that if you dealing with scenario of the surrogate next of kin station, don't ask, do you want anyone else to be here in this session? Please don't ask, because they are those people that you allow to invite is not, we don't know whether the patient actually got consent to talk to you or not. Okay, so that's why it's important. And generally for this kind of scenario, it's also good to offer a bit of a support group and also discuss on in terms of the care at home, but it's a bit too detailed. Like I mentioned, end of life care is like another topic. That's why it's always good to just limit yourself. What are the things that you want to discuss? If you go in with this kind of like a keywords or a simple framework, then you will not able to stray away. You will know what you are going to discuss. Eh? So you will not suddenly mention palliative a bit early. Okay, so you will know if you have to write a framework. For some reason, you have to still write something on your paper to know that what are you going to do next. Okay. So I got one question. If family member asks how long is the patient life expectancy, how should we answer? Yeah. So sometimes we don't have to tell them offhand a certain numbers of days or weeks like that. You can just remain neutral. You just say that we know. I'm very sorry to tell you that we all know he already have this late stage cancer, which already spread to possible bone or even the lung. We don't know where's the primary source. And we know that the life expectancy in this population of patient is will be reduced. But in terms of how long, unfortunately, I cannot tell you, because different patients can progress differently towards the end. So it's very difficult for us to tell. But our goal is to make sure that your father is uh, be as comfortable as possible throughout this last journey of life. We're going to offer him a lot of support, including pain medication to reduce the distressing symptom, for example, for any reducing the secretion, making sure that he can still pass a bit of motion, making sure that he is not having any difficulty in terms of sleeping or behavior. So all those things that something, those are the things that we can answer, huh? But we don't have to really tell them the answer like how long exactly, because we really don't know the trajectory for palliative patient. It depends on we are. I mean, if you've been through palliative posting, one of the things that the palliative doctor always mention is the trajectory of a person towards the end of life, and the trajectory can be very different, and doctors tend to be very poor in actually predicting the trajectory. Okay, if we are very poor, we are totally very poor in predicting the trajectory. So therefore, it's difficult for us to tell, and we don't have to commit ourselves. But our main goal is not to know how long the patient left, but it's mainly for family members to be prepared and what are the things that they can help in this scenario. Okay, all right. So if you have no other question, we will go to the last candidate. The last candidate for tonight will be Jonathan. Jonathan, are you there?
Yeah, I'm here. Can you hear me?
Yeah, your voice is clear. So if you are ready, we will start, and then you have 4 minutes to prepare. Your time will start now.
Okay.
Okay, 4 minutes up. Let's start.
Okay. Hi. Good evening, Mr. Sean. I'm Dr. Jonathan, one of the doctors in the clinic. May I confirm if you're Mr. Sean, 55 years old?
Yeah, I'm Sean.
Yeah. I hope that you didn't have to wait too long, and I'm sorry. I want to apologize for having you to wait so long because today.
No, doctor, I really waited very long. 4 hours, How come I have to see you also have to wait so long?
Yeah, I'm really sorry this happened because I think unfortunately today there's a lot of patients, but we are working on that to make sure your next review or the other patients' next review wouldn't have to wait so long. I really apologize for that.
Oh, okay, all right. So,
Mm, yeah, Mr. Sean, thank you for coming to see me, Mr. Sean. Actually, I got a letter from your GP saying that had some problems with controlling your blood pressure. I just want to hear your side of the story. Would you want to tell me more regarding this?
yeah, I don't understand why my GP forcing me to see you and forcing me to take medication. I really feel nothing unusual at all. Why should I take medication, doctor?
Hmm. Okay. Mr. Sean, actually, your GP actually has your health at his first place, and he really put your health at his your best interest. So actually, during a checkup, he 2 years ago noted that your blood pressure was actually high, and that is the reason he has started you on the medication, and so that he can control your blood pressure, Mr. Sean.
But
Are
I
you
don't have
aware?
any symptom, doctor. Why should I take this medication?
Yes. Mr. Sean, actually, a lot of us, a lot of patients with high blood pressure actually does not have any symptoms. They can be very normal, even has no symptoms, no pain, nothing at all, but actually they have a high blood pressure, and if this is undetected and if this continues, actually it has can affect our health in the long run, Mr. Sean.
What are the things that what are the long run thing that you're mentioning?
Sure, Mr. Sean. If you allow me, I would like to explain it to you. Do feel free to stop me anytime if you have any, if you feel overwhelmed or you have any questions. With this high blood pressure, actually, it can affect a few of our organs in our body, such as our eyes, our kidneys, in our heart and our brain. So I think the most common one, our brain, sometimes it can lead to put us in higher risk of getting a stroke. That is a bleed in our brain or even a clot in our brain, and this may cause us to be to lose some functions of our brain, such as weakness and numbness. And sometimes, if this bleed is very big or this clot affects a large part of brain, actually it can cause long-lasting and even permanent disability. Regarding the heart, sometimes I think the most common one will be heart attack, where there's a clot in the heart causing the heart muscles to not some part of our heart muscles to fail, and it sometimes it can cause heart failure, where the heart gradually becomes bigger and bigger and becomes weak as well. Other things that can affect is our basically our vessels in our legs, and then it can cause us can cause can cause leg pain also. Sometimes can cause clot in the leg as well. It can also affect our eyes and causing to us to have some blur in the vision, and also affect our kidneys. And so in the long term, our kidneys might not function properly, or even may even require dialysis, which is which might even at the end require dialysis.
Okay, doctor. I think you are very scary. You tell me all the things that can face. But doctor, you don't understand. This medication has been affecting my sex life significantly, you know. I feel very bad for my wife.
Okay. Mr. Chan, may I ask this, has this started since the medication has been started? I mean, this affecting your sex life, is it after the medication has been started?
I really don't know, you see, because after I put on this medication, initially was nothing. Then subsequently I have difficulty for erection, you see. And this has really, really made me very, very pissed off. That's why I
Okay.
don't feel like taking medication. I think this is due to the blood pressure medication.
All right. Mr. Sean, your concern is very valid. And after having a review at your medication, and thank you for telling me this concern, Mr. Sean. And after reviewing the list of medications that you have, pertaining to this, you do have a medication called metoprolol, and that can the one of the side effects, not everyone has it, but one of the known side effects is it can affect can cause some erectile issues. And regarding this, no worries, Mr. Sean, we can always change it into another medication that will not have this side effect. There are a lot of the blood pressure lowering medication that we can offer to you, Mr. Sean.
Okay.
Apart from this sex life being affected, is there any other side effects that you have encountered after starting this medication that is causing you to be reluctant in taking the medication?
No, doctor. But you see, if you change me on another medication, but if these things still happen, then what is the option left, you see?
Okay. Yes, Mr. Sean. So after we change your medication, we'll definitely follow you up regularly. And if this still happens, we'll refer you. Regarding this erectile issues, we'll refer you to the appropriate team that will help co-manage with us regarding
doctor.
this problem. Yes.
Let's just be frank. Sorry, doctor. Let's just be frank. Is it okay if I take Viagra on top of my blood pressure medication?
Yes. You can take Viagra also at the appropriate dose.
Okay, so I can take it and there's no issue, because I heard some people are saying that they may have heart problem, cannot take some medication together with Viagra. That's why I'm very concerned.
Okay. But yeah, definitely at the end of this clinic, I will definitely do a check your heart, do electrocardiogram just to check your heart, even do a scan of your heart and see how is your heart function doing. And then we'll definitely get back to you on that regarding the Viagra consumption. But yeah.
Yeah, it's okay. So look, doctor, if let's say you change my medication, I'm still not very keen, because I really tend to be very forgetful. I cannot comply to take medication at the appropriate timing. What is your suggestion, doctor? Oh, sorry,
Okay.
1.5 minute left.
Okay, Mr. Sean, definitely, you're not alone in this. We'll definitely journey with you. One of the suggestion that I can offer is, maybe we can set an alarm that I sometimes offer to my patients is we can set an alarm on our phones that will remind us to take our medication on time. Other things will be to probably have a family member or have a friend to remind you regularly to take your medication. Sometimes you can have a medication box that will help us to remember to take our medication daily. Yeah.
Doctor, do you all have this medication combination option that I don't have to take so much pills every day?
Yeah, definitely. If your blood pressure is still not controlled, with after being compliant, then if you still feel like it's difficult, we'll definitely there is some medication that can have two medications at the same time, as in combination pills that have two medications inside, and we do have this medication as well, and then we can definitely offer to you as well.
Okay, doctor.
Yeah. Any other concerns you have for me, Mr. Sean?
No.
Before we end this, I will give you a brochure regarding the importance of controlling blood pressure. I hope you're not too. Hope you will be able to
Okay.
understand.
Okay. Thank you, doctor. Okay, thanks
Alright.
out.
Thank you.
Okay. Yeah. So, how do you feel about your performance?
I knew he was going to be angry, but not so. I think I didn't manage to really calm him down. I think I further scared him, so not sure how I could have done it better.
Do you think a better approach perhaps should be, asking the reason of non-compliance first?
Oh yeah,
Yeah,
yes.
because the main dish of this scenario is the non-compliance to medication, right? And to deal with this non-compliance scenario, we really need to ask the question of why, and keep on asking why, because the reason may not be just one, maybe multiple, and maybe hidden agenda as well. If I don't tell you about this erectile dysfunction thing, which is calibrated as the main point, then you may not able to get that point, and you may not able to score in this station. So it's important that you really need to know to address the fact that what is the reason that causing the patient non-compliance, because that is the main issue that's being tested in this com skill. It was one of the scenario that I took from one of the university exam. They are having practice, but it's actually online based. I just take this kind of similar scenario and I modified a bit. But mainly the principle for that scenario is really to test on the reason of non-compliance. So the reason of non-compliance is two, right? First is the sex life activity being affected because of erectile dysfunction. So your suggestion is to change the beta blocker to another form of antihypertensive. And if it's persistent, then perhaps you should also explore whether any roles of giving this PGE1 inhibitor, okay, the for example the Viagra so-called sildenafil. And what about when the patient asks you, when you ask the patient, not the patient asks you, it's supposed to be the inverted, and why the erectile dysfunction occur, do you think? I mean, how do you tell about this, whether or not this is due to medication or due to hypertension? It's difficult, right? You cannot tell.
Yeah, that's why I was thinking whether I was trying to get the chronological thing. So she said that it happens after he started metoprolol. So
Yeah,
but
but
definitely
at the same
hypertension can
time,
also,
you have to
yeah.
remember that you cannot take history, for this kind of scenario.
Yeah.
It's mentioned as such, and yes, you can only take whatever words that the patient tell you. But generally, it's important for you to know, in the subsequent slide I will show you, which can be very beneficial in terms of counseling. So I will leave it to the back later. And in terms of the counseling with regards to the timing and the pill burden, you should always offer to change to the fixed drug combination, even without patient asking. Because it can reduce the pill burden and potentially increase the compliance. At the same time, the alarm and the reminder thing that you mentioned is good. It's something that you should mention routinely. And I think you address the emotion quite okay, but perhaps not to focus much on the long-term complication first, instead of addressing the reason of non-compliance first, then followed by what is the potential side effect if the blood pressure is not controlled. But I think this scenario you should have time to actually explore a bit more of non-pharmacological management for this patient. It is not just medication. You must also counsel on regular exercise, weight reduction, practice a healthy lifestyle, adequate sleep, and nutrition. You should always mention about this. Although the scenario just mentioning about non-compliance medication, right? But we know that management of hypertension not just medication, right? It's always about the lifestyle intervention and modification. That's why for this scenario, it's also important for you to also just mention briefly on those non-pharmacological intervention. That will make your consultation more complete and more thorough. Okay. All
Okay.
right. You have any question, or anyone have any question to ask me before we proceed? No question. So for your performance, I think you do quite well. I would say that your critical skill communication is good, is satisfactory. You also address the concern very well. Your judgment, yeah, I mean judgment is one of the things that maybe the examiner will mark you down by borderline or satisfactory, but potentially you can hang between these two depending on the examiner depending whether they like you or not in terms of your style. But I think your management is okay. It's just that you need a bit of prompting. What I noticed is that the consultation seems to be driven by the surrogate instead of by you, because you are also to Q&A kind of session to answer the patient or the surrogate question only mainly, and you doesn't seem to have a very framework. I cannot feel the framework other than the last one you do a summary lah. That will be the last ending. But it's always important for you to have a framework so that you can see that your approach is there. And maintaining welfare, definitely you got most of it. Okay. And I like the fact that you spend a bit pause to address the patient emotion, in the sense of patient is unhappy for waiting too long to see you, and the patient is also unhappy that the GP refer him to see you, thinking that he is normal and asymptomatic. So I'm actually happy that you actually give some time to address that emotion. Just let the patient rant, and then only then you need to talk about what is going to do next. Okay. So if I'm going to write an approach, just a brief one, probably I will write in my paper those the introduce emotions or idea. I will just write it 3 words like that, and then I will mainly focusing on what is the reason of non-compliance I need to explore. Okay, of course when I was out and when I prepare scenario outside, I won't know lah. But those are the things that we need to anticipate. Okay, so this kind, the main reason is actually erectile dysfunction. So what are the options available? You can switch to the medication that potentially will not cause erectile dysfunction. Like I mentioned, one of it is the metabolol, to switch to other option. Refer to men's health for counseling of the so-called PDE4 inhibitor, which is sildenafil or Viagra. Yes, you assure the patient that actually it's safe to take Viagra together with the blood pressure lowering medication. However, there are certain medication like nitrates. Those medication tends to dilate your vessel, and it may not be good if you take this together with Viagra. And that what happen is, if you take those things together, you may have a very low blood pressure because of the effect of these two medication. You can just explain it in very simple word to clear the doubt. But generally, for most of the blood pressure lowering medication, don't have any issue or interaction. Okay. And if the patient, I decided not to ask you further because I know the time is a bit tight. But let's say your flow is very smooth, I may also ask you, let's say you change already, but still fail. What are the options, doctor? Okay, so you can also, this is a bit more advanced, but don't need to know most of them, but you can say that I can also refer to the urology colleague. They sometimes can do some form of small surgery or recommend some device to actually improve and to reduce this difficult for erection. Okay, so there is some EBD, for example, vacuum erection device. There is some intracavernosa injection and also some prosthetic implantation as well. This is all a bit too technical. Of course, we are not expected to know all that, but it's always good to know that there are some options available, so that during your counseling, you don't have to mention in detail. You just mention that we can always consider referral to our urology colleague and see how they can help you. Okay. And another thing is that the non-compliance because of the timing issue, working schedule, then you can always suggest a reminder. And then frequent dosing, therefore, is like change to once daily combination pills, okay, to improve the compliance. And perhaps the second important point that I will discuss is the complication of uncontrolled hypertension. You have mentioned quite well, I would say. It's just that you mentioned it quite early, no? But another thing you didn't mention is the heart failure. I mean the cardiomyopathy part, and also the confusion or headache. You mentioned about the symptom of uncontrolled hypertension. And you also mentioned about eye vision and also the kidney disease. Okay. And generally, you, like I mentioned, you also need to mention about the lifestyle modification. Okay. And followed by concern and offer the leaflet brochures and also website as well as support group, hospital contact. Those are the usual thing. But for this discussion, the more important thing is to address the fact of non-compliance. Okay. So just back to this ESC guideline, one of the ESC journal publication. It's a long one, but I just want to highlight this fact that you can see that erectile dysfunction is vasculogenic, and majority of the cases is due to atherosclerotic lesion in the arteries. And why is that happening? It's because these penile arteries are actually smaller than coronary arteries, and this erectile dysfunction tends to manifest earlier than the symptom of the heart. And it usually experiences 3 to 5 years before the appearance of symptomatic coronary artery disease. And therefore, it can use as an early diagnostic sign in the asymptomatic heart disease. So you can see that when you counsel him, you can always see that, yes, it may not be due to medication. There is a possibility that this difficult erection can be due to your uncontrolled blood pressure, because we know that in uncontrolled blood pressure, it always predisposed to a narrowing of the heart vessel. And this narrowing of heart vessel, if you mind, if I explain further, our private aerial vessel is actually more narrow than the heart vessel. And when you experience this difficult erection, it's hard to tell whether it's due to medication, or at times it may be due to an early manifestation that there is some narrowing of your vessel. Therefore, you have this symptom. But regardless how, you need to optimize your blood pressure. Okay, you can mention something like that, just in brief. Okay, and the conclusion, I like this conclusion because it really gives us a good idea. What are the antihypertensive that is potentially causing erectile dysfunction? First of all, in this patient, is the beta blocker. Whether it's actually not all beta blocker though, just most beta blocker can actually, non-selective one can actually cause erectile dysfunction. And diuretic are the common one, the furosemide, whether regardless is looks diuretic or this potassium sparing diuretic. Any form of diuretic potentially can also cause erectile dysfunction. And centrally acting agents, which is like metadopa, all those things can also cause erectile dysfunction. And how about those that neutral doesn't really cause narrowing or vasodilatation of the penile arteries? Is actually your calcium channel blocker and the ACE inhibitor. And the medication that's potentially beneficial antihypertensive is actually the ARB. ARB has shown that they are potentially beneficial, but what if you look through the literature in detail, it does not really improve the erectile dysfunction, but it improves the quality of life. Patients generally will feel better in terms of their symptom, although they may still experience erectile dysfunction, but they generally have improved quality of life, and therefore it is still recommended as potentially beneficial agent. And nevibalol, another beta blocker, is beneficial. So you can see that this is their conclusion. So of course, patient with erectile dysfunction, you won't know is either due to the uncontrolled hypertension per se, vascular disease, or it's due to the medication. But we can always switch to the medication that is least able to cause the erectile dysfunction, and we observe the patient, and we also offer some medication like Rega, also some urological consult. So this will be how we target this erectile dysfunction. Okay, is anyone have any question? If not, I think we will call it a day very soon. Yeah, I think everyone is quite silent, right? So yeah, Jonathan, you got any question?
No question. I was a bit confused regarding the Viagra, I mean sildenafil and the antihypertensive, because you asked me twice, then I got shaken a bit because I didn't know that.
Because I also try to threaten you because I want you to commit. What is your answer? Because in exam, this is quite common. They want to know the maturity of our thinking. How are we going to answer this kind of question? You see? So if you're not sure, you can mention you're not sure. But in this kind of condition, you say not every medication, you can give a very neutral answer. Sometimes you don't have to commit yourself like in detail. Some medication may potentially cause further drop in blood pressure if this sildenafil is given together. But please rest be assured that we will not give you such medication. Okay, you just mention like that. Then it's okay already. I won't ask you again. Okay.
Okay.